Well, I'm delighted and honored to introduce our next speaker, Dr. Ashraf Rushdy. He is on faculty at Wesleyan University, and that's where he works, and he holds three professorships there. He's the Benjamin Waite Professor of the English Language, he's Professor of African American Studies, and Professor of Feminist, Gender, and Sexuality Studies. He was born in Cairo, Egypt. He completed his BA and MA in English at the University of Alberta in Edmonton, Canada, and then his PhD in English at the University of Cambridge. He completed that in 1988. He's a prolific author. He has written 9 books, and 4 of them I wanted to just give because they're relevant to his topic today. A Gilded Age, Apologies for the Past. After Injury, A Historical Anatomy of Forgiveness, Resentment, and Apology. Philosophies of Gratitude. And his most recent book, which is The Forgiveness of Others. He's received a number of awards, grants, and fellowships. He has a huge teaching dossier at Wesleyan, and he's a highly regarded thesis supervisor and examiner. His main field of research is in African American culture and history. He has published work on the representation of slavery in African American culture and politics. He's also written on the history of lynching in American culture. He's written on the practice of political apologies. And his most recent work is an exploration of the philosophical concepts of resentment and forgiveness. His work raises a key question about what we can do with an unacceptable and violent past. That is, what we can do with the historical forces that forged the world we inherit. He's interested in the range of options different artists, philosophers, and intellectuals have offered for confronting that past, from those who dwell in the history we inherit, to those who resist it in different ways, to those who struggle to find some kind of redemption in and from it. His work is so timely, I think, in our current epoch. The title of his talk is The Moral Emotions in the Theater of Work. Please join me in welcoming Dr. Rushdy to Downstate.
Thank you very much for that generous introduction. Thank you indeed. I'd like to thank the conveners of this conference for their kind invitation, allowing me to participate in this symposium with you, and especially Dr. Myers, who has been as gracious as he has been supportive. Second, I would like to acknowledge upfront my limitations, the limitations of my knowledge about your field of work, the theater in which you operate, both metaphorically and literally. My medical training consisted of 3 summers working as an operating room porter in a Western Canadian hospital during my undergraduate years in the early 1980s. The surgeons and nurses in that hospital largely felt that the important part of the job description was porter, the wheeling of patients into prep and the wheeling them out of post-op back to the ward, and I was not consulted in any meaningful way on anything else to do with the operations. Because of that deficiency in my training, I beg your indulgence where I fail to understand or get wrong those things that will be obvious to you. A declaration in one modern variant of the Hippocratic Oath, written in 1964, says, "I will not be ashamed to say I know not." That seems like good advice for all of us, no matter what theater of work we occupy. What I hope to do today is address what I do know a little bit about and what I think are important preliminary practices that serve as the foundation for conflict resolution and compassion. Those practices involve what philosophers call the moral emotions, and my interest is in how these emotions, these practices, can create a workplace culture or a theater of work where conflict is less likely and where its resolution is more likely because those preliminary practices are already in place. We can begin with some definitions. A theater of work is a physical space where at least two things happen. First, the work intended for that space is performed by those trained in it. And second, the work of training the next generation of workers takes place there. It is a site of both professional activity and apprenticeship. In medicine, that space is where you spend or spent your rotations, internships, residencies, and fellowships. That then is the space we're talking about, the sites where we want to understand how compassion can prevent, temper, and repair conflict. Next, the participants in that theater generally fall into three categories. Professional, the one who does the work and the training, in your case, the attending physician and medical school faculty. Apprentice, the one learning on the site, medical students, residents, and fellows. And client, the one on or for whom the work is being done, in your case, the patient. These then are the individuals who are potentially in conflict and for whom the issues of resolution are important. Finally, let me identify what philosophers call the moral emotions. Since antiquity, philosophers have made the case that ethical actions ought to be motivated by an attendant emotion, feeling, sentiment, something not simply rational, but heartfelt, something not simply cognitive or capable of being justified logically, but something that is deeper and beyond that. Consider a scene from Socrates' final days. In his prison cell, awaiting his execution, Socrates is urged by his students and friends to escape Athens and save his life. He tells them that it would be wrong and unjust for him to do that. He bases his argument not on the logic of laws or some categorical imperative of obedience to the state. Instead, he says that he would feel shame because he would have betrayed the Athens that provided him his education and the culture for which he feels only gratitude. These two emotions, the possibility of shame and felt gratitude, are what motivate him to stay and suffer execution. What is important for us here is to recognize that the moral emotions have what we can describe as different trajectories. When Socrates feels gratitude, he feels an appreciation towards others for a gift that others have given him. When he feels shame, he feels a self-conscious failing to live up to his own standards. One is directed outwards as appreciation, one inward as self-judgment. Likewise, as David Hume and Adam Smith argued in the 18th century, when one feels indignant at a perceived injustice, one feels an emotion directed outwards as judgment. And when someone feels sympathy that makes him or her compassionate for the welfare of others, that person feels an emotion directed inwards to appreciate that the other has a self with equal claim as one's own self. The emotions then can be classified by their direction towards the self, towards the other, and by what we can call their tenor, judgment, appreciation. A moral emotion can promote judgment of self or other, or appreciation of self or other. To sum up then, we have identified a particular site, the theater of work, the participants, professional, apprentice, client, and the kinds of tempering activities that can make that site more or less productive and make the participants more or less engaged, the moral emotions. Now, we can try to get a better sense of the potential conflicts and a better sense of how they arise in the specific case of your work, the field of medicine. Conflict resolution is a necessary feature of any human social arrangement. Moral practices such as remorse, confession, apology, mercy, and forgiveness help us resolve the inevitable conflicts that would otherwise fester and undermine all of our relationships with those whom we love and those with whom we work. Conflict is simply an inescapable factor in human activity, it would seem. The 19th century German philosopher Arthur Schopenhauer compared the human condition to a set of warmth-seeking porcupines. They huddle together for warmth, and then they flee each other because of their quills. The need for society, he writes, which springs from the emptiness and monotony of men's lives, drives them together. But their many unpleasant and repulsive qualities and insufferable drawbacks once more drive them apart, unquote. Schopenhauer was a notable misanthrope who loved dogs considerably more than fellow humans. But his point about what Immanuel Kant called the unsociable sociability of human beings has some merit. We irritate each other. We annoy. We insult. We alienate and hurt. We seek power and feel deeply the inequities of power in our relationships. But enough about family. Let's now add to this potent scenario the stresses of work that involves regularly making life and death decisions, not metaphorically, but literally, and people whose medical education requires them to be sleep deprived for a decade or so. This would appear to be a recipe for deep and repeated conflict. I personally witnessed some of that kind of conflict firsthand when I was a well-rested operating room porter, but mostly I rely on what medical students and practitioners have themselves written. One described his residency as moving like a clockwork human in a dull haze for 2 years. In the first 6 months, he had witnessed more than a dozen deaths. Added to the cycle of being on call every third night and seeing so much suffering and loss of life was the fact he, like every other resident, felt persistently judged by the attending physician. Quote, I have never seen senior residents in surgery, grown men and women with 6 or 8 years of operating experience, so deflated as when the attending simply shook his head in dismay. The residents have been sensitized to this mild expression of disappointment, one suspects, because they have been taught both by what this doctor calls kinder, gentler instructors, but also because they have been taught by those who are not. Lewis Thomas, the former dean of the medical schools at Yale and NYU and later president of Sloan Kettering, noted that the word dehumanizing is used as an epithet for the way that doctors are trained and for the way they practice. Writing in the early 1980s, but recalling his own medical education in the 1930s and his father's before that at the end of the 19th century, Thomas sees both the benefits and costs of the new array of technologies and therapies available to medicine by the end of the 20th century. His father made house calls, and his father's office was in his own home, and he primarily diagnosed diseases for which there was only palliative treatment. The students graduating from the medical schools of which he was dean worked in what he, Lewis, described as huge, alarming clinics or within the walls of terrifying hospitals, and they were expected not only to diagnose but also to heal or cure those diseases whose progress his father could only observe helplessly. The medical profession was in a crisis, Thomas thought, because people had expectations of doctors that medical training in that day and age could not, or at least did not, teach them to meet. That mix of stresses and inequities and imbalances, that setting in which differently situated people have different expectations, constitute the conditions in which we find conflicts. And the truth is that the conditions are not likely to change when we seek for ways to resolve those conflicts. We can briefly identify some of the kinds of conflicts that will arise in the theater of work in medicine. I remind you again of the 3 participants we defined earlier: professional, apprentice, and client. From now on, let's just call them attending, resident, and patient. Residents sometimes feel bullied by attendings, some of whom might indeed feel the pleasures of unequal power, but most of whom I suspect simply believe that rigor requires a particular tone and that medical training should have travails of a rite of passage, which is the way they experienced it. Patients often feel alienated and unheard. Thomas writes about those critics who claim that doctors, quote, are concerned only with the disease at hand, never with the patient as an individual whole person, unquote. Unlike the disconnect between attending and residents, which is premised primarily on inequities in power, the disconnect between doctors and patients is also premised on quite different understandings of what a doctor is supposed to do. Given these potential conflicts with each population in the theater of work, attending physicians might well feel unappreciated as they heal and train, wondering perhaps whether her or his job is to be kind or to cure, to be a buddy or a teacher. Certainly many doctors have articulated that disenchantment. In his ominously titled book, The Rise and Fall of Modern Medicine, James Lefanu reports the stark increase in doctors who are disillusioned in their work. In 1966, a cohort of doctors was asked if they had regrets about choosing their career, and 14% said yes. That rose to 26% in 1976, 44% in 1981, and 58% in 1986. Those surveys were taken in Britain. More recent surveys conducted by the United States Physicians Foundation and the American Medical Association have 68 and 61% of doctors expressing regret in 2022 and 2023. Let me conclude this section on conflicts in your field by noting two things. First, as in every field of labor, the social pressures and historical conflicts of our larger world affect the dynamics within our theater of work. This is explicitly recognized in the medical profession. The most recent version of the Geneva Declaration from the World Medical Association states, quote, "I will not permit considerations of age, disease or disability, creed, ethnic origin, gender, nationality, political affiliation, race, sexual orientation, social standing, or any other factor to intervene between me and my duty and my patient." This is indeed a laudable aspiration. Would that more professions had the integrity to make explicit their standards of conduct in this way. Of course, we live in a world and a society where that task of not permitting those factors to affect your work is difficult to do and difficult to recognize when we are not doing it. Implicit bias is insidious precisely because it is implicit. It is more felt by the recipient than by the person inadvertently demonstrating it. For that reason, as two Johns Hopkins bioethicists argue, it is important for clinicians to hear what patients who feel they have been subject to bias have to say. The title of that Johns Hopkins medicine story is "Physicians More Likely to Doubt Black Patients." An analysis of taped conversations between physicians and Black female patients revealed that doctors dominate the conversation more with African American patients than with white patients, and they don't ask as many questions. Analyses of doctors' written reports, now widely available since the 21st Century Cures Act gave patients access to their electronic health records, show that doctors are more likely to express skepticism about symptoms reported by Black patients. The consequences of not listening, or listening as if one already knows, are deadly. Black women die of pregnancy-related complications at 2 to 3 times the rate of white women in this country. And from the other side of the stethoscope, African American women doctors predictably report that same experience of not being heard, being discounted, and having to surmount assumptions about their abilities based on their race and gender. The point I'm making here is that there are conflicts within the conflicts, social pressures that go beyond, but nonetheless directly impact the theater of work. The second point is about preferences. If someone asks me whether I would prefer treatment from an oncologist who always exhibits a humane concern for each patient and has a great bedside manner, or an oncologist who might lack some social skills but is singularly focused and knowledgeable about the sources of the ailment and the repertoire of treatments for it, I know I would choose the latter, and I suspect most people would do the same. But I also believe that this is a patently false choice. For one thing, as we've just seen, those who don't attend to the patient as a patient, listening to her and not presuming to know prematurely what is wrong, put the patient's life at risk. The choice is not between having a good bedside manner or being a gifted diagnostician. The choice, it seems to an outsider anyway, is between a doctor who can heal because she is attentive to all the information she needs, or one who might fail because he isn't. To sum up where we have traveled so far, we have identified the place, the actors, and the potential and specific kinds of conflicts in that theater of work. We can now turn to the ways that conflict resolution can work and needs to work, not only to create a more welcoming and amiable workplace, but also to make that workplace better suited to do the very work of healing and training that is its mandate. The conveners of this conference have wisely identified one comprehensive moral emotion, compassion, as at least an element in conflict resolution. What I'd like to do now is consider some of the constituent practices that make up compassion broadly defined. In this section, and the one that follows, I'm going to suggest that in general, a strategy for conflict resolution is more likely to be successful when that strategy emerges organically from the particular site where those conflicts arise, and then when it applies that strategy with an eye on what we can call the culture of that site. A strategy to resolve conflicts within a marriage and a strategy to resolve conflicts within an international dispute, for instance, are not going to look the same and will not draw on the same texts. One will explore disputes by examining marriage vows and expectations, while the other will draw on prior treaties and international norms. In the case of medicine, the original text is, of course, the Hippocratic Oath, or for most physicians today, one of its many modern variants. I suspect that most physicians now use the Declaration of Geneva, first crafted by the World Medical Association in 1948 and then revised in 2017, or one the Dean of the School of Medicine at Tufts University, Louis Lasagna, proposed in 1964, or one of the other new variants that seem to appear every couple of years. What most lay people know of the Hippocratic Oath is one phrase, do no harm. It is worth noting that that phrase occurs in the third paragraph of the oath, after the initial prayer to the gods and goddesses of healing, and after the first declaration, which is, quote, to hold my teacher in this art equal to my own parents, unquote. So beholden to the teacher is the student that she vows to make the teacher a partner in her livelihood, to share money when the teacher is in need, and to teach without fee the members of the teacher's family. The oath begins then with a declaration of what gratitude means in actual lived behavior. It begins, in other words, with a felt emotional experience that can be manifest only in particular actions. Before doing no harm, be grateful. The Declaration of Geneva also highlights gratitude, but in this case, it is more widespread. Quote, I will give to my teachers, colleagues, and students the respect and gratitude that is their due. The addition of respect is important, following in the Enlightenment tradition of Kant, who argued that respect was in fact the foundation and hallmark of all moral action toward the self and toward the other. The Geneva Declaration also has a physician pledged to respect, quote, the autonomy and dignity of my patient, and to respect the secrets that are confided in me even after the patient has died. And as we saw earlier, the Geneva Declaration describes the range of social identities that deserve equal respect from the physician: age, disability, creed, ethnic origin, and so on. That addition, by the way, came in 2017. The original 1948 declaration simply used the golden rule to describe how one should behave. Quote, a doctor ought to behave to his colleagues as he would have them behave to him. Moral emotions, in other words, have come to play a greater role in medical practice. The 1964 version has that the doctor should acknowledge, quote, that there is art to medicine as well as science, and that warmth, sympathy, and understanding may outweigh the surgeon's knife or the chemist's drug. The Imperial College of Medicine made the moral emotions part of their declaration of a new doctor. Quote, I will practice medicine with integrity, honesty, and compassion. Here, then, we can find a range of moral emotions in the very texts that inaugurate a career in medicine: gratitude, sympathy, compassion. These are not wholly autonomous emotions, of course. There is a great deal of overlap in the life of the emotions. Nor are they inert emotions, ideally anyways, since they often do move us to action. Let me offer an example. If we feel grateful to someone for a kindness and do nothing, not say thank you, not offer a gift as an expression of our thankfulness, are we in fact grateful? The very origin of the Western sense of gratitude in Hellenic culture was founded on the idea of reciprocity. Less important than feeling grateful was demonstrating gratitude. Homer's Iliad, we recall, begins with a feud over a gift. Agamemnon takes back the gift that he had given to Achilles, and Achilles storms off and refuses to fight against the Trojans. Achilles complains about the ingratitude he has been shown, and then Agamemnon has to offer him a significantly enhanced set of gifts to persuade him to return to battle. Gifts, in other words, are a form of currency, and it is from the ancient Greek culture that we get the language of debt in gratitude. I owe you a debt of thanks. We still retain that concept in some ways. We owe them a dinner invitation, one couple might say about another. But we have also moved away from straightforward reciprocity to something else, where material things can be met with symbolic statements. There is another emotion attendant on gratitude. Ancient Greece also highlighted the emotion of pride. To be proud meant not to be indebted, and therefore not to feel compromised if one could not reciprocate a grandiose gift with something even greater. That sensibility might still play a role in our modern life, but it is not as admirable to us, nor pride so positive an emotion. Instead of pride, Western values have celebrated humility, which is a crucial emotion when it comes to gratitude, since we feel grateful when we recognize that we are undeserving recipients of the gift at hand. What Achilles felt was that he deserved the gift, and therefore it was really no gift, and gratitude was not the proper response. So we can see how the single emotion of gratitude incorporates a suite of other emotions as preconditions for its existence and expression. We are humble enough to recognize that we would not exist without others. We appreciate the gift of existence and the gifts that mark our relationship with significant others, and we are therefore grateful for the material gifts as periodic expressions of that relationship. Our sense of gratitude is both local and general, both for the gift and the cosmos. Given this constellation of emotions, actions, beliefs, and ideas integrated into one emotion, in this case gratitude, I will hereafter refer to these emotions as practices. The practice of gratitude, the practice of sympathy, the practice of compassion. These are not simply feelings or sentiments, but attitudes, habits, and attentiveness to conditions. How important are these practices to the practice of medicine? Can a physician's warmth, sympathy, and understanding, in a word, a doctor's compassion, outweigh the surgeon's knife and the chemist's drug, as one medical oath states? Maybe, maybe not. I'm not even sure what a double-blind clinical study that attempted to find out would look like. It's hard to imagine how lack of concern and care could be cast into a placebo for the control. It is clear, though, that many who spend time thinking about how best to train doctors believe these practices are crucial. How crucial? One medical school dean proposed that twice a year, the lecture hall in molecular biochemistry should be exposed to a silent aerosol of adenovirus so that the whole class comes down at once with the flu. Schedules being what they are in medical school, this will assure that a good many students will be obliged to stay on their feet, working through the next few days and nights with their muscle pains and fever, and learning what it's like not to be cared for. Good for them, the dean continues, and in a minor way, good for their future as doctors. In that way, Lewis Thomas argues, future doctors would learn sympathy. There is no evidence that Thomas ever instituted this pedagogical practice, and it is not likely in our post-pandemic political climate that any current dean would even make that suggestion in print. There are, fortunately, other ways to learn sympathy in the sense Thomas meant it. That is, not feeling pity for the plight of another, but feeling with the person in the plight. That term, the term we now use to describe that moral sentiment, is empathy, a term which is a little over a century old in English. Empathy involves imagining ourselves in the state of others, feeling their pain, and sharing in their joys as if it were our own. Sympathy involves detached observation, while empathy implies felt engagement. And it is felt engagement that those 18th century Scottish philosophers, Hume and Smith, described when they used the term sympathy to identify what they classified as the key moral sentiment for human ethics. It is empathy that the German Jewish physician who produced the Oath of Maimonides in 1783 meant when he writes in that medical oath, quote, "May I never see in the patient anything but a fellow creature in pain," unquote. Let's now turn finally our attention to how to put into practice those practices of the moral emotions in the theater of work. For the sake of time, I'm going to focus on one practice, the practice of apology. The moral emotion behind apology is remorse, and the moral end for which apology strives is reconciliation, in our case, conflict resolution. As we saw was the case in our discussion of gratitude, apology also exists within a constellation of other moral practices. To feel remorse, we must be attentive and empathic enough to see that others have been harmed by our words or actions, humble enough to recognize that we can and have hurt another, compassionate enough to know that we have a duty to repair that harm. Apology also coexists with forgiveness, a practice that likewise incorporates mercifulness, equanimity, and understanding. The concept of apology in American life has a curious history. On the one hand, there is a rugged frontier sensibility in which it is seen as a sign of failing masculinity. John Wayne's character in the 1949 film She Wore a Yellow Ribbon has a signature line, quote, "Don't apologize, it's a sign of weakness," unquote. In 1988, George H.W. Bush proclaimed in a similar vein about the nation whose vice president he then was, quote, "I'll never apologize for the United States of America ever. I don't care what the facts are," unquote. Maybe he shouldn't have said never. 3 years later, his signature was the bottom of the letter of apology that was sent to all survivors of the Japanese American internment camps. Later politicians would echo Bush's anti-apology sentiments. Mitt Romney's 2010 book is titled "No Apology: The Case for American Greatness." In addition to seeming to exhibit weakness, apologizing is also seen in American life as a sign of legal precariousness. To apologize is to take responsibility and therefore to open oneself up to a lawsuit. When Bill Clinton, for example, was contemplating apologizing for America's role in the slave trade during his first state visit to Africa, his advisors worried publicly about the potential such an apology would have for those who would then claim reparations. When Congress finally did issue an apology for slavery 2 decades later, just in time to land on the desk of Barack Obama to sign, the Senate version explicitly stated just that. The bill reads as follows, quote, "The Congress apologizes to African Americans on behalf of the people of the United States for the wrongs committed against them and their ancestors who suffered under slavery and Jim Crow laws," unquote. Two sentences later, it ends with a disclaimer stating, quote, "Nothing in this resolution authorizes or supports any claim against the United States or serves as a settlement of any claim against the United States," unquote. That, then, is the way apology has been represented in American culture. Don't apologize, it makes you look weak. Don't apologize, it leaves you open to litigation. Now, let's consider the practice of apology in the theater of work for medicine and what role it can play and what form it may take. It would seem that both the sensibilities we just outlined are to be found in medicine. First, there are surely physicians who, like John Wayne, reject apologizing as a sign of weakness, as something compromising their pride and the unquestioned authority they feel they need to do their work. Likewise, a physician saying "I'm sorry" has legal implications, and many malpractice policies have stipulations about doctors admitting liability. It is worth noting that as of 2022, 39 states in America have enacted evidentiary rules that make expressions of sympathy following an accident or error inadmissible in civil court to prove liability. These provisions enable physicians to abide by the American Medical Association's recommendation in the Code of Medical Ethics, quote, a physician's concern about legal liability that might result from full disclosure should not affect his or her decision to deal candidly with a patient, unquote. In other words, it would appear that there are fewer disincentives to giving the practice of sympathy and sometimes apology a more important place in medicine. To avoid abstraction, let's consider three scenes in the theater of medical work. I'm going to describe what happened, and then I will humbly offer what role the practice of apology, which is a component part of compassion, might have played if it had been exercised. Please remember, this is the view of an outsider, one who has never experienced the particular stresses that come with the work you do. Consider it the perspective of a well-intentioned operating room porter. First scene. A 12-year-old child overhears a doctor and a nurse behind a curtain partition talking about the patient. The patient is his mother, and she has been admitted for a drug overdose that is clearly a suicide attempt. She has been admitted to this hospital in the same condition on several prior occasions. The boy hears one voice complain about having to do all the paperwork for her admission again, saying angrily what a waste of time it is. The other voice jokes that maybe this will be the last time, and they both laugh. They are unaware that they have been overheard, and so the story ends there. What, though, if they had drawn the curtain and seen the 12-year-old son of the patient? What might they have done? Or suppose a different scenario, where the unconscious patient was obese and they made a callous remark about his or her weight that had nothing to do with the diagnosis or treatment. Or a situation in which they made what was clearly an inappropriate comment about a person's appearance or condition. These things happen everywhere, of course, and they shouldn't. The question is, obviously in an ideal world, they wouldn't, but we don't yet live in that world. The question is, what should now happen? Here's where I'm going to suggest that what would be best in this situation is a partially true apology. The person who made the inappropriate remark should simply say, "I'm sorry, I was wrong to say that." This will be the most effective thing to help resolve the potential conflict and repair the damage. Why partially true? Because in my experience, a person who gets caught saying that kind of thing is usually not remorseful. The kind of fully true apology in which they say, "I'm sorry you heard that," is not an apology for the harm. It is an expression of sorrow for getting caught. It's just like that other common expression, "I'm sorry if you found that offensive." Okay? These kinds of expressions are not going to do much to resolve the conflict or repair the harm. In this case, sincerity of emotion is less important for conflict resolution than the articulation of it. Second scene. A surgical resident is in the operating room for the very first time, assisting a renowned surgeon who's described as being famously brilliant, but also for being a belligerent and arrogant prima donna when he operated. The resident is nervous and breathing heavily into his mask, which causes his eyeglasses to fog up. His inability to see clearly increases his nervousness, and he begins to sweat profusely. A large drop of sweat rolls off his face and lands on the sterile field of instruments. The surgeon goes ballistic, yells, and ultimately kicks the resident out of the operating room. What precisely has the surgeon, whose role in this particular moment is both to perform and to teach, taught the resident? It would seem that the surgeon taught only what was least attractive about his own personality. Years later, this resident became eventually what he self-described as, quote, "an arrogant, egotistical neurosurgeon," unquote. What was possible at that moment was for the surgeon to teach how compassion and rigor can coexist. What would have been best in this situation is what I'm going to describe as a preemptive apology. Let me explain. Almost all scholars of moral emotions agree that someone who apologizes for what they're about to do is not apologizing. They're asking for permission or license. One does not say, "I'm sorry," for a future action. A spouse who says, "I apologize now for any affair I might have in the future," is not apologizing. But in the theater of work where stresses are episodic rather than consistent, a preemptive apology might have a role to play. Suppose this surgeon had taken all the residents aside in a calm moment and said, listen, let me apologize in advance for what might sometimes seem like a harsh or insensitive tone in my comments or even moments of anger. Please do not take these personally. What you will realize as you become doctors is that there are times where you don't have time to be sensitive to others' feelings in that moment. I want you to know that I am sensitive to them now, and I apologize for future occasions when that sensitivity is not apparent. What a preemptive apology can do then is establish grounds of trust that will not be irreparably harmed later in the moment of conflict. It would have been a very different experience for the resident had the surgeon said something like that prior to the surgery and then approached the resident afterwards to say that he was sorry he went ballistic, but that was one of those moments. Had he done that, of course, he would likely not have had a reputation in the hospital as a belligerent prima donna. Third scene. Another surgeon is in an operating room removing a medulloblastoma tumor from a 4-year-old child. All is going well, and the surgeon is removing the last of the tumor that is attached to the posterior fossa venous system. The senior resident who is assisting him lets his attention wander for a millisecond, and in that moment, the suction that the resident is holding tears the vein. The 4-year-old boy goes into full arrest as blood pours into the resection cavity. The surgeon has to work blind because the blood makes it impossible for him to see the retracted vein in order to clip it. The resident's hands are shaking too much to provide him with any assistance. The surgeon does in the end manage to clip the vein, stop the bleeding, and save the boy's life. The surgeon does not tell us what happened later, what kind of conversation he might have had with that resident. I would like to imagine that it was considered and measured. I would like to imagine the surgeon saying something like, listen, that wasn't great what happened in there. I'm not sure what to make of it, but it looked to me like you lost focus for a second, and I want you to reflect on what happened here and think carefully about how to attain greater focus in the future. As for the handshaking, that just happens sometimes. My hand started shaking once when I was about to clip a pulsating aneurysm whose wall was so thin that I could see the blood swirling within it. I had to step back, sit down, take some deep breaths, and then continue. Obviously, that wasn't possible in this operation, but I do want you to know that you are not alone. These things happen. I'll share some information with you later that has helped me develop ways to gain and regain focus. In the end, I want you to remember this moment so that you can become an even more attentive and skilled surgeon in the future. Let's go together and tell the parents the good news. The reason I imagine this conversation instead of one where this surgeon goes ballistic, like the other one, is that the memoir in which this servant recounts this incident is dedicated to the Dalai Lama. It is also the memoir of a person who founded Stanford University's Center for Compassion and Altruism Research and Education. Those are two pretty good reasons. But I also think that his experiences as a resident who was thrown out of his first operating room he entered, and as a 12-year-old who heard callous, insensitive remarks about his mother from people whose job it was to heal, also informed his sense of compassion. It is both the positive examples and the negative experiences that form that sensibility. Now, let's imagine that it was not the friend of the Dalai Lama, but the arrogant, egotistical prima donna who was having that conversation with the resident. What happened in there, the surgeon says heatedly, is inexcusable and convinces me that you have no future in surgery. What kind of idiot are you? Maybe you should become a humanities professor where the harm you do will at least not likely be fatal, though still widespread and visceral. Or better yet, why not just wheel the gurney with that patient you almost killed back to the pediatric ICU and bring me the next patient? Let's see if you can do that without endangering anyone. What should the resident do with that? with relentless negativity from a prima donna instead of what could have been a benevolent, teachable moment from a compassionate soul. I have so far suggested two unorthodox ways of thinking about the practice of apology. First, partially true apologies, and then preemptive ones. Here I am going to offer one more heretical suggestion. The resident should assume an apology where one was not offered. I would like to say that this idea has a long philosophical tradition that we can trace back to some Hellenistic school of thought, the Stoic tradition maybe. But to be honest, I read it in an article about Taylor Swift. The writer said that one of the best pieces of advice he'd ever seen about how to live a happier life was in a sign in a parking stall. Quote, "Life becomes easier when you learn to accept the apology you never got," unquote. The sentence comes from Robert Broe, an 87-year-old freelance writer with a gift for elegant and pithy wisdom. The wisdom is that in the absence of compassion in our interlocutor, our teacher, those with any power over us, we can invest our own compassion and grace. Translate what the prima donna said into what the Dalai Lama might have said. Honestly, of course, attending to the crucial lesson of how to confront momentary failure, learn from it, and develop strategies that increase the chances for future success. To sum up then, what these three scenes teach us is that the practice of apology in the specific context of medical practice is valuable in the twin duties of teaching and healing. It is valuable as a form of compassion because apologizing requires us to see the harm as it was felt by the other. It is valuable as a strategy for conflict resolution because it changes the tenor of conflict. It is no longer about assigning blame retrospectively, but about reestablishing the level of trust and amity required to move forward meaningfully. It is also a part of that suite of moral emotions that we outlined earlier that make us considerably more bearable human beings. Selfless empathy, humble gratitude, and focused attention on others. What an apology does for the recipient is demonstrate concern. What it does for the person offering it is signal openness. What it does for the theater of work where it occurs is make it a healthier, more congenial, and ultimately much more productive space where those who heal and teach and those who heal and learn can both do that much more effectively. Thank you.
Ashraf, thank you. Thank you so much. What a tour you've given us. And you've got an audience here of medical students, residents, surgeons and non-surgeons, deans, et cetera, et cetera. You've spoken to all of us. So let's open it up for questions. Please, anyone, feel free to unmute yourself and ask your question or make a comment.
I would love to make a comment. Well, firstly, that was such a different style for us MDs. So this kind of humanities talk and lecture is such a wonderful compliment, and really just such a pleasure to learn in this way. But the preemptive apology was very interesting for us. It really has some parallels to what we do when we are trying to establish something called psychological safety, which is thrown around a lot in medicine. But it's really about establishing expectations. And while we try not to establish an expectation of our faculty behaving badly or abusively, we don't accept that as something we really want our faculty to do. But the idea of preempting, I think, does normalize the situation and at least helps the student's ego, to understand it wasn't about them. It was really about the faculty member. So what, in a way, I might have said, take it further and express it in a way of vulnerability and humility. Like, I have certain deficits. One is that I lose my temper. I'm working on it. But just so you know that about me, and sharing what that might be perceived as a fault. So that really spoke to me, that particular story, and sort of bringing it into our world of expectation. So thank you thank you so much again. That was just so great.
Thank you.
Dr. Bianchi.
Yes, good morning. First of all, I also would like to really express gratitude for an amazing presentation. Thank you, Dr. Rushdy. It's more of a comment that what I love about this is sharing different perspectives, and I think of the many inspirational points that you brought here. One that never thought about is the idea, perhaps, that towards the end, with the third case you expressed, of a compassion that someone can offer on behalf of somebody else. I think it's a sort of the apology specifically is we see that as an individual action, but you made, I think, an important point that all these moral elements of moral emotions will work if there is a culture of it, if the whole enterprise develops them. So I think with that, you gave us a very powerful, important tool that probably I honestly never thought of. Don't leave, in essence, the apology to the individual who's been involved, but maybe you can share that and help whoever received that, whoever was hurt by whatever behavior. And maybe even if the individual doesn't offer the apology or doesn't offer it ideally, maybe as a colleague or supervisor, whatever, you can help reaching out to the person who's been hurt. Is this reading fitting, or I'm totally off?
No, it's very fitting. Let me say it's important in one way. It's important because, as you say, it does change the culture of the place. There, in some situations in our own individual interpersonal lives, we might find a place where we forgive someone because that person's a friend before they apologize, and it inspires a remorseful feeling in them. So, in other words, it changes the culture of that place. On the other hand, I also want us to be cautious because we don't want to normalize abuse. We don't want to say, we'll just, here's the preemptive apology, and I know you're going to act this way, and that's acceptable. So it goes hand in hand with changing the culture of the place and changing the practitioners' attitudes and behaviors within that culture too.
Thank you.
Thank you. Thank you, Ashraf. Dr. Bruton Foster, and then Anastasia Dewey.
Thank you. Thank you very much, Dr. Rushdy, for being part of this symposium. And as you talk about a preemptive apology, I often think of what happens in classes that we teach that focus more on the biopsychosocial aspect of care, the more humanistic elements of the provider-patient interaction. And this is an area where we also discuss some of the political and social drivers of health. And this is a space where there may be a difference of opinion and interpretation. But what I like about the preemptive apology is that to me, it signals that someone is reflective on what they're about to say and recognize that not everyone will receive that information in the same way. And then I think if it's done appropriately, it also invites feedback. So I'm going to discuss a topic that may be viewed as controversial. I think it's important to bring it to this discussion. I think there's merit to sharing it, but I also recognize that it may not land safely for everyone. So I invite your feedback. And my goal is to improve upon it. So I think it opens up the opportunity for feedback.
Yeah, I think it does. And of course, a situation in which it's not in the crisis, but well before, helps establish, ground rules and expectations and develops a sense of compassion in those who are going to be subject to that abuse later. So it's always better to have rules in place before rather than during the actual crisis. And it's always better, as you say, it opens up feedback. It's always better for those rules to be commonly, formulated and with a shared understanding of them. So they can, everybody in that moment, like that one resident in that moment, can reflect back and say, yeah, we were all together. We heard this. I now know it's not personal. That's also important, that the dynamic in which those rules are articulated is in a group. Yeah. Thank you.
Ashraf, thank you. Anastasia?
Yes, so I just wanted to chime in to talk a little bit about the preemptive apology as well, because I really love that concept. In medicine, we talk a lot about anticipatory guidance, preparing patients for what to expect. So I think preemptive apology functions in like a similar way in teaching and leadership. So when an attending or a supervisor says, I know it can be very blunt when I'm stressed, I'm working on it, they're offering anticipatory guidance for the emotional landscape of learning. It doesn't excuse the behavior, but it does humanize it, I think, and it turns hierarchy into a dialogue. So just like telling patient what side effects might come with a medication, I think a preemptive apology also builds trust by naming imperfection upfront. It creates space for honesty and psychological safety and repair for things when things inevitably get messy. So I really love that and wanted to echo everyone's sentiment, but from a trainee's perspective, if this is something that my attending would do, like that would be something that I would really appreciate. So I wanted to echo that.
Thank you.
I think I might be next. So
Yes, you are. Yeah, please go ahead.
So first thing, this may sound kind of weird, but you've got a great voice. It's just very pleasant to listen to you. I don't know if anybody's ever told you that, but as I'm listening, I'm just like, wow, this is fantastic. So that's part one. Part two is that the apology that never comes or that never came, that resonates with me because as a med student, I did some crazy things. And I was in situations where an apology didn't come, but I learned from that. I learned what not to do as an attendant, and so the apology that you don't receive could turn into an apology that you then offer when you're in, a position of leadership or something like that. So that apology that never came concept really resonated with me.
Thank you very much.
Thank you, Dr. Jose. Amanda Lopez.
Hi. Yeah, first of all, what a great lecture. You're an excellent lecturer. Your students are very lucky to have you. It really took me back to both my high school and undergraduate days, thinking about hubris and the classics and stuff like that. So my mind was very on, which was lovely. Yeah, I just wanted to comment on the idea of gratitude requiring reciprocity, and then kind of the flip side of that, as I saw it when you were speaking, was that apology also has this kind of reciprocity. Does an apology really mean anything if you don't mean it? And at the same time, sometimes an apology is necessary, even if it's disingenuous. I thought that was something that I don't always think about in the patient interaction. It can what everyone is getting out of everything else can feel very murky sometimes because there's a set of questions you need to get through and specific information that you're trying to elicit from the patient. So all the kind of filler conversation doesn't always seem valuable. But I think that thinking about those two things, the gratitude and the apology, kind of hones in on the parts of those conversations that are really valuable to the patient and also to you as a provider. So I appreciated that as something to think about when I'm having those kind of more difficult conversations with patients. So thank you for that.
Thank you. Just to follow up on that point you raised about apology. Of course, emotions, when they are sincerely felt, are something different than emotions that are simply expressed. That I think no one's going to disagree with that. But we also have to remember that these practices, the practice of apologizing, the practice of gratitude, they are means to an end. And so we shouldn't hold them hostage to the end, saying, look, I don't feel remorseful, I'm not going to say anything. If the end you want is conflict resolution so that the job is done and the workplace is healthier, that's why I'm suggesting that at some points, in some occasions, it's not important what you feel. It's important what's important is what can be said at this moment that will communicate something that will accomplish an end. So, but again, if they're felt, great.
Ashraf, thank you so much. On behalf of everyone here, I really appreciate you joining us today. All the best to you.
Thank you all very much. I really feel honored.
Thank you.
Thank you.
Thank you. Turn it over to Dr. Jacobson-Dickman.
Thank you so much. And Dr. Rushdy, you're certainly welcome to join, but we also do understand if you have a busy day. So wonderful for you to be here.
Thank you.